If I could have the first slide, please. Now, data scientists have exploited the new computational data capture tools as if it replaces the mass in the famous E equals mc squared equation of Einstein in an attempt to enlighten us to the energetic analytical interpretations on new insights into human behavior, labeled as the black box of artificial intelligence. The virtual reality Ventari platform applied in the simulated environment for the first time in medical education, using the virtual human for learning invasive procedures in critical care medicine, similar to airline pilots in the flight simulators. This virtual learning experience is targeted at critical care trainees, essentially to minimize errors and harm to patients who are already very ill. I can get the second slide, please. The virtual reality modules exposes the trainee user to a one-to-one learning experience. That is, the user works with a one-to-one relationship with himself, whereby his experience is directed, tracked, time-stamped, analyzed, and available in near real time to him compared to a standardized model developed by knowledgeable-based experts in the procedure itself. Each user experience is passed back to the trainee user and the tutor until a desired standard is achieved in a virtual simulated environment before the trainee is exposed to a patient in need of the procedure itself. The learner datasets are analytically tracked by a standardized tutor model to the decision nodal tree that you see on this diagram, mapping the user behavior to follow many nodal pathways, which we prefer to call augmented intelligence, which is a better term describing it in medical training. All of this is such, and if I could have the next slide, please, that with repeated user experiences, the learner user attains a degree of competence whereby he moves from being consciously competent in the upper right to unconsciously competent in the upper left. This learner experience is intended to minimize transgressions into the lower two panels, on the lower two quadrants, whereby the user is consciously or unconsciously incompetent, and thereby exposing the patient to harm because of poor technical training. At this point, I would like to ask Dr. Vijay, Paul, and Jay Kalon to demo the Ventari VR platform system, beginning with placement of a central venous cannulation, and then demonstrate some excerpts from test tube insertion and pulmonary artery catheterization. Over to you, Jay and Vijay.
Brilliant. So now as Jay is able to transmit to you, there will be a small lag because of bandwidth, but in real usage, this is a seamless, fluid experience. We are transmitting this as a shared screen at the moment. And basically, you are able to see what Jay can actually see in his virtual reality environment. So at the moment, the equipment that's being used is a Oculus Quest 2 headset, which is a totally immersive head-mounted display virtual reality headset with a link cable that is connected to a computer. It could be either a desktop PC or a laptop, as long as it has the appropriate graphics processing unit of sufficient standard. Now, as you can see, we are inside a completely immersive virtual environment. This is an operating theater that has been modeled based on one of the quaternary hospitals in Sydney. Inside this full operating theater, we've actually reused it for ourselves, for our platform, as the lobby. So this functions as a lobby, and you would have seen Jay pick up the clipboard, and there are some instructions on how to get started for the new user. He's able to interact with any of those pieces of equipment on the trolley. And that's complete real-time simulation, complete dynamism. So that's quite exciting. Now, if Jay's able to look to the left, moving a little bit slower, Jay, because of the lag, you can see a procedure selection screen. So as you can see, our focus has primarily been in critical care medicine and associated procedures. The central venous catheter, the internal jugular insertion on the bottom row is something that we'll now demonstrate. This was the first project that we actually kicked off with Professor Yugen years ago, that actually formed the basis of how the platform evolved in subsequent years. So once you select the procedure of your choice, you'll be in this complete virtual environment. The appropriate equipment will be available to you as laid out on the trolley. There is a virtual, if you look down a little bit, brilliant, thank you, Jay. And just to comment on the equipment, so they are actually modeled according to the real life instrumentation. So they're digital reproductions faithfully reproduced. So you can see even the very kind of intricate detail on the chlorhexidine bottle, for instance, even a labeling on the forceps, the scalpel, and what have you. If you look to your left, there's a virtual patient. Jay, if you can hear me, thank you. Yep. So the virtual patient has been placed in the appropriate position for this procedure. There is also an ultrasound machine, which is the Siemens ultrasound machine, which has been reproduced in the virtual environment. Now we'll be able to see some really interesting capability within the platform as we go through it. So Jay, if you want to get started.
Perfect. I will go ahead and get started. Just please let me know if I'm moving too fast. So first, the virtual facilitator is talking to me, and I have muted that virtual facilitator. This is the gold standard way on how to do an ultrasound guided central line placement, but I will enable remote education capability where Vijay is sitting across thousands of miles from me, and he can walk me through the procedure itself as well.
Brilliant, thank you, Jay. So yep, there's a virtual trainer with a narration, and you also have the checklist of steps. So as you can see, if you're a complete novice trainee or a medical student, you'll be able to come in here and actually have self-directed training without having to have a senior on hand, because the virtual trainer will provide for you. In this moment, I'm guiding Jay through, so he's currently following the checklist, but as we get to some of the more interesting steps, I'll guide him through. Thank you, Professor Sandeep. All right, so some of the steps that are not critical to learning autocomplete, like draping the patient, because that's not really what we're about training at the moment. You know, the core functionality and sort of the learning from this procedure will be to be able to use the ultrasound adequately, to appreciate how to insert the chest, the central venous catheter, following the correct angle and depth as you approach the palate puncture. So those steps will be, you know, we'll really dive into that and kind of discuss those. So Jay's gone through the first 5 steps, is now drawing up some cell line to prepare the catheter so that it can flush all the lumens and get it prepared. So as Jay completes various steps, the steps will tick off, and you also hear a tone that actually, you can hear inside the virtual environment. Now, while a person is doing this procedure, there's actually data being gathered on the back end. So as a trainee, you have access to your training data. We'll dive into the LMS a little later. Now, the star of the show is the ultrasound. So this is the dynamic ultrasound capability that Vantari has created within the platform. So as you move the probe, the ultrasound within the virtual environment moves dynamically. As you can see, Doppler has been enabled as a default to be of assistance to the trainee. There's the vein and the artery. Now, this dynamic ultrasound capability has been is something unique to Vantari and has currently a provisional patent on that technology. Now, you can basically move either, well, Jay's just turned off the Doppler, but you can actually move obviously in cross-sectional views or inline views. Jay, if you want to turn on the Doppler and then kind of show inline views as well.
Perfect.
Thank you.
There you are.
Yes. So just cross-sectional and then just inline. Thank you. Perfect.
Perfect.
So now that's inline views. So, you can actually do the procedure with both approaches, as preferenced by the clinician, or even to check for, your correct angle or insertion, guide wire, and things of that nature.
Perfect.
So if we're able to go on to the next step.
Perfect. So I will go ahead and do an ultrasound guided block.
Yep. So to start with, as part of the procedure, is able to basically inject some local anesthetic in the appropriate area before he gets started on the procedure itself. So within this, you can see the needle, but you'll be able to see it more clearly with the pilot puncture. So Jay, if you want to complete, and then we'll come back to the sort of needle component in the pilot puncture. Perfect. So, all right, interesting choice with inline. So Jay's now able to, now he has the pilot puncture needle. He's able to insert and see. Now you can see the needle very clearly in the inline kind of insertion. If you can move the probe a little bit to get a better view of the vessel.
Yeah. There you are.
Yeah, perfect. Yeah, that's good. Excellent. And then as you can see, he's had flashback into the syringe. So there is immediate feedback visually and also auditory feedback as you pass this step. So he's successful in obtaining the pilot puncture in the correct location. Now he's able to fit the J-tip guide wire through. Thank you, Jay. So that's
No
good. So at all times, you have to perform and be cognizant of best practice. So as you move, make sure you hold on to the guide wire. And if you're not holding on to the guide wire at all times, when you actually remove, for instance, the needle or use things like the dilator, then the platform will recognize that and mark you down. So you will fail that step and that will be recorded. Because as you all know, some of the complications are not holding on to the guide wire and going into some of these steps, such as the dilator step, and accidentally burying the guide wire inside the patient.
One thing I will point out, Vijay, is I'm getting a lot of resistance when I access with the dilator. So there is built-in haptics, which is giving me feedback in terms of losing resistance when I'm accessing with the needle, or when I'm inserting a bigger dilator, giving me haptic feedback.
Brilliant, thank you. And that's a great point. So there is the significant haptic conversation. So for those of you who don't know, haptics is the concept of what kind of feedback that you get of fine movement or resistance, which you do get as you do real procedures. So that haptic component or the physical technical feedback you get as you do a procedure. So we'll cover haptics in just a second, but Jay was just pointing out that he didn't follow best practice and he let go, and therefore that remove dilator step has been marked in red. So the platform has recognized that and has marked him down for it, which will be actually captured in his learning management system. So as you do the next step, I'll talk a little bit more about the haptics there, Jay, so you keep going. So with this haptics, just something to say is that data shows that of the 100% of learning a procedure, 70 to 80% is the cognitive ability of learning the procedure. So when we say the cognitive component, we're talking about the steps, the approach, what to do when things go wrong, the knowledge base. And 20 to 30% is the haptic component, which is the physical actions that you learn as during the procedure. What virtual reality is really good at is teaching you 100% of that 70 to 80% cognitive component. And the haptic conversation is still being addressed for virtual technologies. So for instance, with the current technology with our controllers, we can actually build in, which we have done, a vibration framework. So there's vibration mimicking resistance and what have you as you do it. But the other stuff is the things you might do to get more sophisticated haptics, such as fine touch. So those things will be enabled by things such as the haptic gloves. So when we're able to do the haptic gloves or desk-mounted haptic devices, we'll be able to address the 20 to 30% more appropriately. So once this is done, perfect. Thank you, Jay. So again, with the railroading the CVC step, Jay had let go of the guide wire and the platform had marked him down. So he's about to now suture in the catheter. Perfect. All right, slow down a little bit. It's a bit lagging at the moment, Jay.
Okay, thank you.
Yeah.
Okay.
Perfect. Yeah.
And I'll do a second suture. There it is.
Yeah, perfect. Yep. So he's completed both the sutures of the fastener on either side. He's now able to apply the dressing, which is an autocomplete step again. And here you actually see complete the step, the time taken to complete the entire procedure, and here you are. So yeah, it's able to then, still dynamic ultrasound. You could ultrasound over it if you wanted. So going back to the main menu there, Jay, and we'll dive into a couple of the snippets that Professor Yugan requested in terms of chest drain and Raha Catheter, or the Swan-Ganz, as it's known. So first up, we're going into the chest drain.
Perfect.
So again, yeah, perfect. Thank you.
One thing
So
we
this
can
is something.
showcase.
Yeah.
Go ahead, Vijay. Sorry.
Now, I was about to say exactly what you were going to say, which is we're able to showcase other learning kind of opportunities within something like virtual reality, which is to actually talk about things like anatomical landmarks. This is a perfect platform for providing that kind of learning. So as you can see, what's the appropriate triangle in which the chest drain will go in? And we've applied that as a see-through or a transparent mechanism. You can see through the skin into the ribs, and where should you actually apply the marker so that you can actually prepare for the chest drain. So that's really interesting. So there are a number of opportunities in which the platform can be used because it's widely scalable and flexible to actually communicate all types of information. And we're about to sort of get into that as well after this is quite wrapped up. So I think if you go on to do up to the, maybe the incision and then the one-handed dilation, Jay, we'll call it there,
Okay.
and we'll go on to the next procedure.
Perfect.
So again,
my-
following those steps, yeah.
On my end, I am getting narration, best practice on how to do the procedure, but I have just muted it just to emphasize that.
Yep, move a little slower, please.
Perfect. You can see the level of fine control and dexterity I have over my hands to be able to go in at 1 milliliter increment, or if I wanted to just go all the way in.
Yeah, perfect. So something to mention here is, Jay, the lag is actually quite significant now. So if you need to slow
Okay.
down quite a bit. Yeah.
Okay, let me know when it's caught up.
Sure. So Jay was then able to perform a simple incision, which we've just, kind of handled at the moment. It looks like that. But at the moment, we prototyped how the platform would extend to do soft body simulation or soft tissue simulation, so that we're able to do more complex incisions and deeper structure manipulation for things like surgical airway. So that's really exciting, and it's something on the horizon for our platform. But this chest drain handles more from the perspective of simple incisions. So Jay's just done the one-handed blunt dissection, and then he's now doing the two-handed expansion. And subsequently, he'll be able to use the one-finger exploration and dissection.
Okay, perfect. And did you want me to stop here, Vijay, and show?
Yeah, we'll stop here and we'll go to the next one. Thank you.
No problem.
It's a great comment from the audience. Thank you.
And I will just show
So we'll
the
be going
setup
on
of
to
the. Go ahead.
So we're going into the Swan-Ganz procedure. So you would have noticed in this instance, it's been called the Raha catheter. Obviously, medicine is moving away from branded phrases for procedures, so that's a reason. But we've also tackled this Raha catheter procedure from the perspective of cardiology for the diagnosis of pulmonary hypertension, but is essentially a elongated version of the Swan-Ganz catheter procedure. So as you can see here, this is quite an amazing sort of part of the development of the platform. Jay was able to pick up the actual catheter, which has multiple lumens, and they have real world physics. So they're able to, Jay, you'll have to slow down. It's laggy.
Okay.
They're able to sort of wave around and flop about as if they would in real life. So that's quite exciting. One thing you might want to show is the balloon, Jay. I always think that's a nice.
Sounds good. So I will withdraw air from the environment. And let me know when you've seen my, when it's caught up that I've seen my syringe filled with air now.
Yeah,
and
that's
I will
good.
connect. Okay, I will connect it to one of the ports, and as I press the plunger, you'll see the air translate to visualize that, okay, this balloon is, this catheter is functional.
Yeah.
So it's 1-to-1 correlation.
That's right. So this is actually expands and contracts in real time. I know the lag makes, oh, there you go. Now it's caught up. So it doesn't go from 0 to 100. It actually goes translationally like that. That's brilliant, just like that. So these are real physics-based medical instrumentation and concepts within VR. Jay.
Yep.
What do you think?
Yep.
Are we able to get to the II? I mean, you'll have to just do a
okay.
Be as efficient as possible.
Okay, perfect.
Yeah.
I'll showcase this. I will speed it up a little bit just to get to, I'll skip a bunch of steps. The platform is super dynamic in the way it's designed, where you can skip a bunch of steps to be able to go ahead and behave and make the same decisions or mistakes that you would in the real world. So we can capture the mistakes to be able to depict it to our learning dashboard.
Sure. Brilliant. So this is one of the more sophisticated procedures on the platform. As you can see, there is a bigger trolley of a number of different instruments. Even in the environment, you can appreciate there is a C-arm scanner. And you would have noticed that there is actually so you can see you actually got access over there. Yep, there you go.
Yeah, sorry, my wire is just getting in the way here. Give me 1 second. Okay.
Perfect. I've just had Jay go a little bit faster because we want to get to this particular point to show some really interesting things. And then that will be sort of the end of it, and we'll go back to the presentation to wrap up and obviously have a forum for questions from the audience. So just the guide wire goes in. So this approach for Waha catheter is a double Seldinger. So, you'll start off with a micropuncture needle. So, typically in cardiology circumstances where they start off with a lower caliber and then move on to a double Seldinger technique for a high caliber lumen.
All right, Vijay, here you go. I'm going to insert the catheter. I'm going to skip a bunch of steps. So you should be able to see the image intensifier now.
Excellent. Can you slow down now? Because it's now super laggy because we were running through it.
Yep. Okay, excellent. So I'll let it catch up. Okay.
So let's demonstrate two concepts.
Okay.
So number one, let's look at the monitor so we can demonstrate the waveforms first. Yeah, so as you can see there's the venous pressures with the associated waveform that are being transmitted on the monitor. So that's actually a dynamic monitor. It's another system that we've created. So as you go through and perform the Waha catheter procedure, the pressures and the waveforms will change as you go through the vascular tree and through the different areas of the heart. So from SVC to right atrium to right ventricle and so on. So in this thing, you know what would be good actually, Jay, rather than doing that, if you bring the Swan-Ganz catheter out, because it should flatline, and then you show, there you go. So see the monitors, oh no, that's a good idea too. So when he turns off the transducer, the wave actually flatlines. And now the wave comes back on when the transducer is back on. So the monitor is completely dynamic, both to the transducer, but also to the position within the heart. Now we'll actually focus on, so that's the dynamic monitor, another unique capability within the Bantari platform. And then the last one I want to show you is the dynamic image intensification. So as you can see here, there is the image intensifier that's being relaying the information as the catheter is inserted. So as Jay goes really closely, you can see that it's actually tracking the location of the catheter dynamically. So you can actually then see and have double confirmation based on the monitor, but also anatomical confirmation as you travel through the II. So this is from a cardiology perspective. So this is a really interesting exercise because it suddenly opens up a whole host of possibilities, not just in critical care, but also in interventional cardiology. And that's cardiology being one of the most exploding fields with the aging populations around the world and more cardiac disease that need management and interventional management. Jay, I think we'll stop that there and go back to the presentation.
Okay, I'll be
Sorry,
right back.
Prof. Yugen, did you have a question? Or
Yeah,
yes.
no, thank you very much. That was excellent. Just want to make one very important point after doing many of these procedures myself, is if they don't get the haptic feedback correct, you do not learn as much as when you're actually doing the procedure in real time. You've got to feel what the insertion of the dilator feels like, or what the insertion of the tracking needle when you're giving the local anesthetic, as well as aspirating the blood when you get into the internal jugular. So those sorts of things, the subtlety with which you get the haptic feedback is crucially important for the learner. And I think I'll leave it there and just let our chairperson take some questions if there are any, and we're quite happy to repeat some of this at different sessions.
Professor Yugen, I would like to wrap it up with one last slide, if I may.
Yep, go ahead.
Sure. So we'll skip ahead to summary AI and VR. So why did we really, we don't consider that these technologies are independent technologies that exist in a vacuum and grow on their own. Now, there is a natural technological confluence where these kind of paradigms come together, such as artificial intelligence and virtual reality. So why do we say that? So for example, in summary, what Professor Yugen touched on earlier in the presentation around, well, we're talking here about artificial intelligence, data, augmented intelligence, as he called it, in terms of decision trees and what have you. We can really break it down if we wanted to conceptually get an understanding of it into data, heuristics, and conversational AI. So Bantari as a virtual reality platform is by its very nature becoming a large data lake, because all of this training and performance data is being gathered from thousands of clinicians and other healthcare stakeholders who are performing procedures. So there's going to be millions of data points. That gives us enormous power in how to address healthcare stakeholders, but also in terms of implementing training paradigms. So we can recognize emerging trends that can be tied back into insights, how we can actually integrate and implement these training technologies. Furthermore, you can link those things back to actual outcomes for patients. So you can make links to, is the medical error rate going down? Are the complications going down? Because you are doing an accreditation or a digital logbook of 10 CVCs or 100 CVCs on the platform before performing them on a patient. So that's important. Secondly, the heuristics. So again, to encourage the mental models of how we approach procedural training, because all of the focus, and not all, much of the focus is on acquisition of knowledge, but certainly not on acquisition of procedural knowledge. So it is more like the traditional knowledge like physiology, pharmacology, anatomy, etc. So, but we know procedural knowledge is very important for patient outcomes. We know as critical care clinicians, that's actually one of the bread and butter components of our practice. And to then talk about this leading to unconscious competence, which Professor Yugan covered. And finally, in terms of conversational AI, because we're here talking about what would AI do beyond data and heuristics and various other things, and it can do a lot, but one practical thing it can do is to have a contextual conversational artificial intelligence. So that would be the trainer in the room. So it would be your, it would be all of Professor Yugan's 50 years of clinical practice knowledge distilled into this AI that can be then passed on to future generations of trainers and learners from an expert. And they don't even have to be in the room, and it could be self-directed. So I'll leave you with some of those thoughts and we can move on to questions.